Okay, we'll go ahead and get started this morning. Again, I'd like to welcome those of you that are just joining us. My name is Leanne Foster, and I am a member of the Provider Outreach and Education team here at WPS. And I want to thank you all for taking the time to join us today. I'd like to welcome you to our study hall, Chronic Care Management. This is the first in a two-part series that we are doing, a back-to-school series this fall. I am going to be handling the study hall today, which is going to cover the information you'll need to know about chronic care management. But as I mentioned, this is the first in a two-part series. Tomorrow, Ashley will be facilitating part 2, which is an interactive Q&A session, and it's titled Pop Quiz, CCM Denials and Rejections and How to Pass. That session is going to focus less on the policy, we're covering that today, but more on common denials and rejections related to CCM, and it will be interactive, so she's going to be asking you to apply the knowledge that you've gained today. So if you're interested in that and you've not yet registered, I would encourage you to consider that, as it will help you expand your knowledge about chronic care management. So just a couple of housekeeping issues before we get started. First and foremost, the training material. The training material for today's event is available on our live events page, and I am asking Ashley to throw that information into the chat. So you do not need to have that in order to participate in today's session, but if you'd like that, if that would help you follow along, help you take any notes, you certainly can go ahead and do that. Once you're out there, you're just looking for the title of today's events, which will be towards the top of the list. You will see a training materials link. By clicking on that link, you will be able to download the slide deck or the PowerPoint presentation for today. You will be sending questions through the chat today. As I mentioned, Ashley is helping me out today, and she is going to be monitoring chat for any questions that you have, and I will be checking in with her towards the end of the session today. I'm also going to be answering any pre-submitted questions. We did receive some of those, so for those of you that submitted those, I do appreciate you for sending those. Some of those pre-submitted questions are included in the material today. We were able to incorporate that in, so hopefully you'll find those answers for you today. Also, after this session, we will be asking for a little bit of feedback. Your feedback is crucial to what we do, and it helps us drive our education and helps us gauge whether or not we're meeting your needs. So both CMS and WPS as a MAC are very interested in hearing from you. So at the end of the session, you will have an opportunity to provide us some feedback regarding today's session. Also, it's your opportunity to provide us with any topics you'd like to see in the future. Next is our disclaimer. I just need to make you aware that the material presented today is accurate as of today. If you've worked with Medicare for any period of time, you know that Medicare rules and regulations do change, and they change often. So make sure that you continue to monitor official CMS and including WPS websites to make sure that you're current with all of the rules and regulations as of today. Also, CMS prohibits the recording, screenshotting, or photographing of this session for profit-making purposes. But as I mentioned, I am recording today's session, and that will be available as an encore presentation on our encore presentations page of our website and our YouTube channel. Should you need to see this again, have any questions, or would like to share it with someone who is unable to attend. I will be sharing with you some CPT and some HCPCS codes today. So this is just the CPT copyright notice that's letting you know that those CPT codes and descriptions are owned by CPT and not WPS, but they also do not have any part in creating the education of today. And lastly, before we get started, I do have one more disclaimer, and this is from the American Hospital Association. Much like CPT, this is letting you know that the American Hospital Association owns the codes that may be used on a UB04 837I transaction, and that they do not have any part in creating the materials presented today. Okay, so today I will be going through chronic care management, and I am going to be utilizing some acronyms on the slides and throughout my presentation today. So I've included just a couple of slides regarding those acronyms so that you have that. I'm not going to go through all of them, but I wanted you to be aware of them and that you do have those should they be helpful to you today. So that brings me to our agenda for today. Pardon me. As I said, today we are focusing on chronic care management services. And today's goal is to provide you with a better understanding of chronic care management services and the billing requirements for those services. So as part of this, we are going to provide an overview of what chronic care management is and why it may be something to consider for you and your patients. There are benefits to both providers and patients, and so we're going to walk through all of that. We're also going to walk through eligibility requirements. That is going to include eligibility for both patients and providers. And we're going to talk through the required elements of CCM. So what services are part of that? There's a pretty expansive list. You're not necessarily going to provide all of the services every single time, but we're going to show you what elements need to be included in order to set that up. And then finally, we're also going to talk about CCM billing requirements. There are separate codes for CCM, and I did see questions come in regarding those codes today. So we're going to be addressing those and showing you that. And also, it's not here on the agenda, but I am providing you with some resources that are going to help you as you walk through CCM and billing that to Medicare. So I want to start with an overview of what chronic care management is. So chronic care management, or CCM, is a program that is intended to provide additional support to Medicare beneficiaries with 2 or more chronic conditions. Now, I do want to point out 2 or more chronic conditions because we did receive some pre-submitted questions about the difference between chronic care management and PCM, and that's the principal care management. And the real difference is here with CCM, it is specific to 2 chronic care conditions, whereas principal care management is 1 chronic or serious condition. So there are going to be some similarities, but we are focusing on that chronic care management today and those multiple chronic conditions. So a chronic condition is something that's expected to last at least 12 months or has lasted for 12 months or up until the death of the patient. The ultimate goal is to help patients manage those chronic conditions and manage their health care overall more effectively, because we want to reduce the number of emergency department visits and hospitalizations to the patient from that chronic condition. We want to get ahead of the problems before they occur. So CCM is a monthly service, and it allows practitioners to bill for at least 20 minutes or more of care that is specific to chronic care management or care coordination in general for those chronic conditions. And I want to be clear that this is a monthly service. It's based on calendar month, not 30 days. Medicare does have some services that you can only bill every 30 days. CCM is a monthly service. So as we go through this and we talk about billing, keep that in mind. The time frame will be cumulative, and you'll want to, your best practice is going to be to bill that on a monthly basis. So for instance, if you see a patient on the 2nd of the month, you can bill, but you may want to hold up until towards the end of the month, just in case you provide any additional CCM services to that beneficiary. And that cumulative time is going to help you bill appropriately. Because the other piece of that is that you can only bill this service once per month. And you don't want to get into a condition or a situation where you bill the service and then you have additional services to bill in that calendar month. Your documentation is going to need to show the time that's spent on the patient. We received a lot of questions about documentation. This is a time-based service, so you're really documenting that time. And this is typically not a face-to-face service. It can happen through phone, through text, through you may have a portal that you utilize in your office. So it's not always going to be direct patient contact where they actually come into the office. What you're going to want to document is all of the time spent on, that's an intentional use of that phrasing, on that patient, and include everyone who provided the services as part of the care plan for CCM. Again, the goal is going to be early prevention, but it's going to include services such as coordinating care across multiple providers and multiple settings. It's going to include creating that care plan. It's going to include managing their medications. It's going to make sure that you're providing 24/7 access to care and their healthcare information. It usually involves regular check-ins, and we'll talk more about some of that later on in the session today. But ultimately, the goal is about preventing problems before they happen or catching them early on, and ultimately improving patient outcomes and their overall health. Sorry, that got stuck just a little bit. So Medicare does reimburse for these services, and the patient may have a small monthly copay. This is one thing that I do want to talk about. There is a copayment, there's cost sharing for this. But if you have supplemental coverage, a lot of times those supplements will pick up that monthly copay. But the idea of CCM, as I said, is to catch those issues early. A hospitalization, for example, can cost over $1,600 for a copay, whereas chronic care management is significantly less, somewhere between $15 and $20. So there's the potential for them to receive years of chronic care management that prevents that hospitalization. It's still going to be a significant savings to that patient rather than that emergency room visit or that hospitalization. So some of the highlights: CCM services are extensive and they're structured so that you're providing a more proactive approach to caring for that patient. It's a holistic approach. You're looking at everything. So as I said, it's a monthly service, but part of that monthly service, what you're doing is you're assessing the patient's medical, functional, and psychosocial needs. This is what you're going to be doing each month. Like I said, it's typically not a face-to-face service. How you implement that, we get a lot of questions on that. That's going to be a business decision for you, but it is something that can be handled over the phone. Maybe it's a video call. Maybe you're using a portal. Maybe there's text messaging that you're using. But those are methods for providing and implementing that service into your office. CMS does not lay out exactly what mechanism is used to provide the care, and we'll talk about that a little bit more. But you're looking at those medical needs. What medical needs do they have? What are their functional needs? What does that mean? So you're evaluating their basic activities of daily living. So things to consider: do they need help dressing? Do they need help bathing, for example? Are they able to prepare meals for themselves? Can they manage their finances on their own? Those are functional needs that you may be assisting with them with, or connecting them to services. We're also, like I said, looking at their psychosocial needs. So what kind of support system do they have? Are they isolated? Do they have a history of substance abuse? Those are things that you're looking at. It can also include confirming the patient has received necessary preventive services. So, for instance, is the patient up for a mammogram? Did they get that? Now, this is certainly not the core part of managing their chronic conditions, but it's part of improving patient outcomes. They have to qualify for CCM with those 2 or more chronic conditions, but we're taking a holistic approach. You're looking at the patient's overall health. So that's why preventative services come into play. Another example would be maybe you're seeing them 1 month, you're communicating with them and reminding them that they have an appointment with the cardiologist that month. And then in the following month, you're following up with them and asking how that went. So again, you're looking at all of the services that they're reviewing. CCM is also going to potentially involve reviewing any medications that the patient is taking for their chronic conditions to ensure that the medication is the best one for them. You also want to make sure that we're preventing any duplications or incorrect dosage. So questions you may be already doing and asking: are they still taking their medications? What medications are they taking? Are they having any side effects? Are there any contraindications for any of the medication that they're on? Are they taking them as prescribed? Maybe you have a patient who's not understanding how those medications should be taken. Are they taking too much? Are they taking them with food when they should? Just making sure that they are effectively managing their care. The other piece of chronic care management is going to be coordination of care. So this can be either with other providers, or this can be home-based or community-based care. So what are their needs? So home-based care, community-based care examples would include things like, are they on Meals on Wheels? Are they part of any senior programs? Or are there any other agencies that are assisting with their health care? Or are you helping coordinate any of that? So you'll be documenting the time that's spent on that patient on these types of activities. You'll hear me say this a lot today. These are oftentimes things you're already doing for that patient, but Medicare reimburses for those services if you're meeting the requirements for CCM. Another part of CCM is that you're going to be managing any care transitions that they have. Now, this is a little bit different than transitional care management. We'll talk about that in a moment. But as part of CCM, you're managing transitions between potentially, as I just said, other healthcare providers, if there are others involved in their care. I gave the example of the cardiologist. You're giving that reminder that they need to see that cardiologist. But then you're bringing that back into that patient's plan of care. You might be doing a follow-up after discharge from an emergency room visit. You may be checking up for transitions between facilities. For instance, maybe they recently had a hospitalization and there's follow-up. You're helping them transition back into the community after that. Those follow-up activities are something that is billable to Medicare. And so also part of those transitions, you are going to be creating a continuity of care with the other providers involved. So you're overseeing that patient's health care for those chronic care conditions, but also their other conditions. This also means that you're communicating with those other facilities or those other clinicians, those other providers. So you're sharing information with them, but you're also receiving information from them. And then adjusting that care plan if need be, depending on what that situation is. You want to make sure that you're using that information. And you're also going to share your plan and any changes to that plan with other practitioners along with the patient. Again, just to make sure that everybody is aware the care is no longer siloed because you're managing those transitions. So before we get into a couple of other things with eligibility, I do want to call out some examples of chronic care conditions. And I want to be clear, these are just examples. They are not, it's not an all-inclusive list. I will be providing you with a resource. There is a Medical Learning Network booklet that CMS has created that does list out some common chronic conditions. But remember, the definition of a chronic condition is a condition that is expected to last 12 months or has lasted 12 months or expected to last until the patient's death that is putting them at a significant risk that you are going to be documenting as chronic. So here you're seeing things such as cardiovascular disease, diabetes, hypertension, things that are very common and we think of as chronic every day. But I also want to point out you'll see depression here as well. So this can be both medical and mental health diagnoses that could be considered chronic. Your documentation is going to be key. You need to document that this is going to be a chronic condition for that patient. We often get the question about whether or not the word chronic is required. The answer is not necessarily. You have to document, though, that the condition meets that definition of having lasted or expected to last the 12 months or until the patient's death, or what, and sorry, not or, and the risk that it's posed, the significance of that risk to the patient. Here I also want to call out that there are two levels of CCM. There's non-complex and there's complex chronic care management. Now they're very similar, They both, and this is a chart that is from that MLM that I just mentioned, they both require that the patient has multiple chronic conditions expected to last at least 12 months or until the death of the patient. They both have to place that patient at significant risk. They also require a comprehensive care plan, and we'll talk about that care plan. The difference here between chronic care management, non-complex, and complex is really the medical decision making that's involved. With complex chronic care management, it requires a monitor high complexity of medical decision making. And when we get into the codes, you'll see that the codes don't really change for the practitioners. But when we talk about clinical staff providing this service, it will make a difference. I just wanted to call out that there are those two different levels. They're very, very similar, and the difference is really just that medical decision making. So that's what chronic care management is. So why would this benefit the patient? What is in it for them? So this service is valuable to patients because it is providing a much more whole patient approach to their health care. It's meant to be holistic because the practitioner and staff that are providing the services, you're looking at everything that's going on with the patient, not just an individual issue. Again, these are typically non-face-to-face services, so there'll be monthly calls, they may be check-ins, and they're not necessarily coming in because they have a problem. You are building a relationship with them to prevent problems related to their chronic conditions. Because they're talking to those same people each month as part of CCM, we'll refer to them as their care team, it's building trust between the patient and the staff or that care team that's involved with their care. And what we find is that this trust is going to lead them to be more likely to share information with you about what's going on with them. So they may be more likely to tell you that something has changed about their health status versus kind of keeping that to themselves and thinking it's not a big deal. It also means they're more likely to listen to the advice that you're giving them about their health because, again, you're helping them prevent it from getting worse. As I said in the beginning, the idea is this is going to prevent emergency department visits for the patient, which can be costly, fewer hospital stays. As I mentioned, there's over $1,600 worth of cost sharing for a single hospitalization, whereas cost sharing for CCM, while it is still there, we're talking about $15 to $20 for each CCM service, but you can see where that could be years of CCM before they would come close to the cost of one hospitalization. Plus, nobody really wants to be in the hospital. So this is really going to be just a better approach to the patient's care for the patient. Better outcomes. So there's also benefits for providers. So one, you're being reimbursed for services that you're likely already providing, at least to some extent, for your patient. You're doing so in your office. So being aware of the structure of this service is going to allow you to decide if this is something that you want to consider and can be reimbursed for. It's going to lead to less fragmented care because you're working with other providers. Again, that continuity of care. You're coordinating services with other providers and other facilities, and you're going to be more aware of everything that's going on with that patient so that they're going to be easier to care for. The care plan that you're going to develop, like I said, is going to include information from all of those other practitioners. So you're a little bit less in the dark about the other things going on with that patient. And it may impact your decisions, your medical decisions for the patient. Again, I mentioned, for instance, their medications. Maybe you'll know all the medications that they're on. Maybe there's something they haven't disclosed in a previous visit. You'll have access to that information. Also, we find that some of the patients that are participating in chronic care management are not requiring as many in-person visits. You're still meeting with them frequently. You're still interacting with them monthly, but they're not in office. Clinicians can provide these services when they're not these non-face-to-face services, and it's going to leave you with more time for either additional visits with patients or more urgent patients. So it's going to help you balance. Like I said, they're typically provided by clinical staff, so it frees up your time just a little bit and just a better overall experience for you in that patient care. So next we are going to talk about eligibility. Now there's eligibility requirements for both the patient and the provider. So for the patient, what we're looking at, as I mentioned, the patient has to have 2 or more chronic conditions, and just reiterating that these conditions have either lasted or expected to last at least 12 months or until the death of the patient, and the chronic conditions are placing that patient at a significant risk of death, acute exacerbation, decompensation, or functional decline. So pretty serious conditions. Your documentation, as I said, we're not necessarily looking for specific diagnoses. It's not based on that. We're looking at your documentation to explain to us that the condition is chronic for the patient. And it could be unique from patient to patient. I showed you that list, and I'm just going to go out to the CMS website. Give me one moment while that window pops up for me. There we go. So out here, you are going to see that the Medicare Learning Network article. So there's a couple ways of getting there. I am one to search. And if you search for chronic care management, you're going to find a lot of things. There are actually some FAQs that are out here as well that you may find helpful. But this MLN 909188 is going to be where you'll want to focus. And I have included a link in your towards the end of your training material today. But here is where you're going to find a lot of really good information regarding chronic care management. And one of those things is going to be examples of chronic conditions. So here is a list, but I just want to be clear, it's not an all-inclusive list. We're not limited to this. It's unique to the patient. So if your documentation supports that that condition that you are seeing them for is chronic, then they could qualify for chronic care management. Again, 2 or more. Sorry. There we go. So for provider eligibility, we did get a few questions on this. So billing providers are going to be your doctors, your MDs and your DOs, and then of course your nurse practitioners. They can submit the service. Those nurse practitioners, just some examples, again, not all inclusive, but clinical nurse midwives, nurse specialists, nurse practitioners, physician assistants. Those are typically the ones that we'll see. These services can be provided by clinicians as long as they are being supervised by the provider. So again, in this case, the MD and the DO or the nurse practitioner. So that's who's going to be able to submit for those services. We'll talk about the clinical staff a little bit later. I do want to call out, we had some questions about rural health clinics and federally qualified healthcare centers. You can submit for CCM services as well. And for the most part, the requirements are going to be the same. There is one difference for RHCs and RHCs in that they're going to be using a different procedure code. RHCs, and we're not going to be talking about just this code, but RHCs will bill for these services using G0511, and they're not going to be using the codes that we'll talk about later. So that's really the biggest difference. Otherwise, all of this, you're going to be going through that same process. So next I want to talk about the required elements, or what needs to be in place in order for you to provide and bill for CCM. First is going to be patient consent. Okay, so this is going to be different from the normal consent that you get. Right now, pretty much probably for every patient, your patients are coming into the office and you're having them sign a consent form, and it's typically giving consent for they're giving permission to receive permission to provide those services, so it's consent to receive services. It's permission for you to release information about their care to Medicare, and for that provider to bill on their behalf to Medicare. That's typical consent. Not an all-inclusive list, but typically those are the big components. CCM consent is different. It's not the same thing as that one overall consent. It is separate because, again, these are typically non-face-to-face services, and there's some things that they need to be aware of. So we have to ensure in that CCM consent, that you're making the patient aware that the CCM services are available. You're explaining to them what it's all about. You're talking about the monthly check-ins, that it'll be billed monthly, that it's not necessarily going to be a face-to-face service. It's likely going to be a non-face-to-face service. You're going to let them know what is available in your office. And then you're going to include in that consent how they're going to be able to access these services and take advantage of them. We mentioned that 24/7 access to care, and we'll talk about that a little bit more, but how are they going to access those 24/7 services? It also needs to include information about the cost sharing. So they have to be made aware that services could apply to deductible and copays may apply. And we talked about that. Even with that cost sharing, it is still significantly less than one trip to the emergency room or a hospitalization. It's also going to call out that only one practitioner can furnish and bill for CCM services during a calendar month. Now, I mentioned earlier that it is a monthly service, but it is also something that can only be billed by one practitioner. If you have a practitioner and a clinician, or a few clinicians involved in the care, there's a care team, it's going to be billed by one of those. It's not going to be billed by different providers at different practices. It's one CCM. Let me step back. CCM can be billed by one practitioner in a given calendar month. And again, it's calendar month. It's not a 30-day service. You also need to make the patient aware that they have the right to discontinue CCM services at any time. This is a voluntary program. They're not required to agree to it. They're not required to continue with it, but we hope that they would find the benefit in and the value in participating and continuing with it. Now, one question that we do get is, let's say, okay, it's August, you've provided some CCM, but they have also just now told you they'd like to stop receiving those CCM services. It's effective at the end of the calendar month. So in that example that I gave, you've provided CCM services. They've also just now given you notification that they'd like to discontinue receiving those services. You've provided the services in August. You will still be able to bill for the services that you provided in August. It will discontinue at the end of August, so next week in my example. In September, then they would no longer be in CCM and you wouldn't be providing those services or billing for September. This whole consent, though, is just really about understanding the services that they are receiving. So you need to include this information, and this needs to be documented in their medical record. Now, one question we do get often too is, how often do we need to get this consent? This consent only needs to be gotten once. It's not every visit. It's once, and does not need to be received again unless they are changing their provider that's providing those services. So let's say that Dr. Smith has received consent and Dr. Smith and his care team is providing chronic care management services. Let's say in a few months, Dr. Smith retires and now they are going to be receiving chronic care services from Dr. Jones and their care team. At that point, because Dr. Jones is a new practitioner, or maybe that patient moved to a new office, that new practitioner does need to receive that consent. But it's not something that needs to be received every single time. The next part of CCM is going to be the need for an initiating visit. So An initiating visit is required for new patients and those that have not been seen in the past year. So if it's been quite some time since your beneficiary came in, that's going to be somebody that we're going to need to see. That's going to need that initiating visit. Now, this can happen during other types of visits. This can be conducted during a medically necessary evaluation and management visit, so just a regular E&M visit. It can happen during an annual wellness visit. It can also happen during an initial preventive physical exam, which is that IPPE, or also known as your Welcome to Medicare visit. It can also happen as part of transitional care management. Maybe that's when you're first considering having this conversation with the patient. And you'll find that transitional care management and CCM can be billed concurrently, but there's some documentation pieces, and we'll talk about those later. But in order for it to be counted as an initiating visit, then you have to document that CCM was discussed. Typically, you're probably getting your consent here as well. So just keep that in mind. The next piece of CCM is a comprehensive care plan. So you do have to have a comprehensive care plan for CCM. Just like with any of your visits, you do need that care plan. But the comprehensive care plan needs to be created, it needs to be revised, and you will need to monitor that. Like I said, you're going to be doing that continuity of care. You're going to be interacting with other providers that are involved in the patient's care for those chronic conditions, and you're going to need to incorporate that into your care plan. It is going to focus on managing the chronic condition, but certainly you will include all of their conditions, in that plan of care. So now there's generally protocols and general treatment plans for conditions, but just remember this is going to be unique to the individual patient. So your care plan is going to include things that are specific to each patient. You may have, for example, maybe you have Bill and Susie. They have the same chronic care conditions, but they're being treated differently. Maybe Bill is a little bit more resistant to managing their care at home. Maybe they're a little bit more stubborn about the treatments. Maybe Susie doesn't have someone to assist her and she needs it. So your documentation is going to have to show the specific care plan for the specific patient based on their specific healthcare needs and their status. It does have to be electronic, and there's a reason for this. It has to be electronic because it allows for your clinical staff to access it in the off hours, because I keep talking about that 24/7 care or access to care. So they need to be able to access it. It can't be, not that I think a lot of people, or many of you probably have anything that's hard copy or paper purely anymore, but it can't be locked up where they can't access that. So it does need to be electronic. And like I said, it has to include the whole health and not just those chronic conditions. You also are going to want to make sure that you're providing a copy of that plan to the patient and their caregiver or caregivers if you have their permission to share it with caregivers. That's an important piece because your care plan is going to include activities that patient may have to do at home. Again, patient education and what they can do for their care. So is it how they take their medication? Is it exercises they have to do? They're not going to be able to do that if they're unaware of what they need to do, and their caregiver is not going to be able to assist them if they're unaware of what is expected. So it'll include a couple of examples I want to throw out there. Are there diet changes that they need to adhere to? Is there an exercise plan that they need to implement, or maybe they just need to increase their activity? Basically, for the patient, the caregiver, it's going to be what are they doing to improve that overall health. So that care plan, getting into the specifics, is going to need to include, first and foremost, a patient assessment. So what are their problems? What's the problem list? Beyond that, the chronic care conditions that are triggering the CCM. So you're going to be doing a cognitive and functional assessment where you're going to determine what their status is. You would determine what type of cognitive assessment is appropriate for your patient. We don't have requirements for which assessment is used, but you just need to perform one. You'll need to assess their environment. Is the patient homeless? Does the patient's home have heat and air conditioning? Do they live with others? And do they feel safe in their home? What is their situation and how does that impact their condition? When I talked about caregivers, the other thing you want to look at is, do they have one? Do they need one? Is that person able to do what's needed for the patient, or do we need to look at getting them some type of a caregiver? Your care plan is also going to need to have clear goals on what you expect to happen. Uh, this is your goals for the patient. What are the goals and the outcomes and that prognosis for the care plan? So it could be a certain amount of weight loss. If they're diabetic, do they have to lower their A1C to a certain level? Do they need to better control their blood pressure better? What are they doing? What is the expectation? How are you going to know that your care plan is working and you've achieved your goal? Because if it's not meeting the goals that you set out, then it's time to revise that care plan. Also, part of CCM is care coordination. I've mentioned this a little bit. Again, you're coordinating with others, practitioners, facilities, community resources, because this is, again, a collaborative approach. We also want to know what interventions are planned for the patient. Is it they're going to come and see you every 2 months? They're going to come in office every 2 months. Is it you're coordinating care with that cardiologist? This could be preventive services. So do you need to have them come in and get blood work once a month? What is the expectation? What are their interventions that are coming up? And you're helping track that and ensure that that's happening. You also want to monitor and follow up with them on their conditions. So these are regular tracking of their healthcare status. There's a lot of ways to do that. Like I said, these are typically non-face-to-face services, but you're going to need to implement ways to monitor and follow up with the patient to make sure they're adhering by that care plan. And make adjustments as needed, because it could be maybe part of that is just not working, like I just said. Are they managing their systems? Or their symptoms, sorry. Do they have pain? Are they having interactions from the medication? Are they having breathing problems? This is, again, going to be unique to the patient. Also, it's going to include any patient education that's happening. So we want to empower the patients with the knowledge to manage their chronic conditions effectively, again, trying to prevent them from either getting worse or further negatively impacting their health. This can be self-care, this can be lifestyle changes, but we do want to educate the patients, again, preventing those problems before they happen. We also want to make sure that we're including any supportive services. This could be community services. Like I said, maybe there's Meals on Wheels. Maybe there's somebody that's coming in that's helping them with some of their daily living. Maybe there's a caregiver that's coming in. There's a lot that goes into this. And what you're going to see here is I have also included a link to a chronic care management checklist. I'm going to go out there real quickly. So this is a checklist that will help you. It goes through what we've been talking about. It talks about eligibility. It talks about that initiating visit. It talks about the consent. And it talks about some of the documentation and things that need to be included. It's definitely distilled down, but it's meant to be a quick reference for you. This is available, and I encourage you to use it to make things a little bit easier. So the next piece that I want to talk about is that continuity of care. So that access, keep mentioning that 24-hour access to care, and you need to make the business decision for you of how you're going to carry this out. Like I said, the access needs to be 24 hours a day, 7 days a week. It does need to be available for both the patient and the caregiver. and it needs to be with the designated practitioner and their care team. So, maybe there are certain hours it's the practitioner, certain hours it's the care team. However you want to set that up, that is a decision for you to make. Some options could be, do they have a phone number that they call? Are they using like a portal where they can send secure messaging and asking for that assistance? How is this going to be communicated to the clinical staff in off hours? Is somebody monitoring that, or is it going to be sent to them? We've gotten questions in the past about whether or not this can be done through an answering service. And it can, that's not a problem, but how is that answering service going to identify that this is a patient that's in receiving CCM services? So it can't be they leave a message and you get back to them, they leave a message on a Friday night, you get back to them on Monday. They're going to need to get back to them in a reasonable amount of time. So how is that answering service going to know this particular contact needs to get to that patient's care team, and then how is that care team going to respond? So you're going to need to designate some things and set up some protocols that make sense for your office to make sure that you're allowing for that 24-hour a day, 7 days a week access to that care. So next we're going to go into the billing requirements. We've covered what CCM is and why it may be beneficial, what the pieces include, what those elements are. Now we're going to talk about our billing requirements. So like I said, CMS is reimbursing for services that you're likely already creating. And we received some questions specific to G0506. And this is creating that comprehensive care plan and that assessment. So CMS does reimburse for the comprehensive assessment and care plan during the initiating visit. This service can be an add-on code to your initiating visit. Remember, we talked about this could happen during a medically necessary evaluation and management service, but it only can be billed once. It's a more extensive assessment for the patient at the beginning. So this is allowing for that additional time that it takes to create that care plan. So it's an add-on code to the other procedure codes, and it can only be billed the one time. Here you're going to see the procedure codes that you will use for a practitioner that is providing chronic care management. So the practitioner is going to use the 99491 for the first 30 minutes. You do need to meet or exceed that 30 minutes in order to bill that, and it's for the month. So if there's multiple interactions in the month, that can accumulate, and then you bill for the time. Like I said in the beginning, you don't want to necessarily bill for 10 minutes that you spent early in the month and then find out that you've got 20 more minutes, or 60 more minutes later in the month. Each additional 30 minutes can be billed with 99437. And with all of these, you are going to want to keep in mind any medically unlikely edits that would have a maximum number of units that you'd be able to bill. They do use the same codes for CCM or complex CCM. You will notice that this is the chart that's in that MLN Networks article. You'll notice there aren't different codes, and that's because you're billing for the time. What I'm going to show you is there are different codes when the clinical staff is providing those. So let's look at that. For clinical staff, for non-complex CCM, they're going to be using 99490 for the first 20 minutes and 99439 for each additional 20 minutes. Again, you want to look at those medically unlikely edits to make sure that you're not going to max out on the codes. With clinical staff, we did get one question, or it would apply to all. We did get one question about how to avoid maxing out on those units if you don't have documentation of the services that were billed. And that's an interesting question. And unfortunately, the answer is you're going to need to do a little bit of an audit on your billing and possibly utilize the self-service tools like our secure portal to see what's been billed to avoid that. Otherwise, if it comes in and it hits that maximum, it is going to deny that code. But again, these codes are going to be for the non-complex chronic care management that's provided by clinical staff. The next set of codes is going to be for complex chronic care management. So the difference here, other than the codes, obviously we have the 99487 for the first 60 minutes and the 99489 for each additional minutes. The difference here is going to be that level of medical decision making. Complex chronic care management involves a moderate to high level of medical decision making. So these are the codes that you'll use there. We also do, as part of CCM, we do have codes that are specific to chronic pain management. This is for the physician or the qualified healthcare professional. This is not going to be clinical staff. And you'll use G3002 for the first 30 minutes and G3003 for each additional 15 minutes. So like I said, and I just want to reiterate, for all of these codes, they are time-based, and you do need to meet or exceed the time for the codes in order to bill them. One thing I also want to point out is how the time counts. So your practitioner time can count your clinical staff time, your practitioner time can count towards the clinical staff time, but clinical staff time cannot count toward the practitioner time. So keep that in mind when you're billing. Here's an example of the practitioner had 10 minutes and your clinical staff had 50 minutes. We'll get the question of how we're going to bill that. Your practitioner doesn't have enough time. They only have the 10 minutes. So you're going to bill that service under the 9487 because the clinical staff spent the most time. But again, that practitioner time can't count towards the clinical staff time. I mentioned concurrent billing. So for the most part, there are going to be some services that are going to be included as part of CCM, and you're not going to bill those twice. But there are some services that can be billed concurrently with chronic care management. And here you're seeing a list of that. For the sake of time, I'm not going to read through these, but I am going to highlight a couple of them. The first one being that transitional care management. That's when you're also managing a transition from a facility setting to the home or back into the community, you can bill both TCM and CCM. Sometimes you're handling the transitional care management at the time that you're deciding, okay, we need to do the chronic care management. You can potentially bill for both. However, your documentation is going to be key. And we did receive a lot of questions about documentation, just kind of general, how do you document it? It's really documenting that these were CCM services versus TCM services. And with CCM, you literally can have a document where on this date we spent X amount of time providing these CCM services. A week later, we provided this amount of time, and then at the end of the month, you're going to total that all up and bill for those CCM services. It is that simple. So just make sure that your documentation is clear. You also see that E&M service. It is possible for a patient to have a medically necessary evaluation and management service in addition to the already agreed upon CCM services in the same month. Okay, maybe they had an exacerbation, maybe there's another diagnosis for another reason they're coming to see you. You can bill for both in 1 month. This doesn't replace those. Things that you can't bill in the same month with CCM would include prolonged care services related to CCM or complex CCM. If that prolonged time is part of those CCM services or the complex CCM services, it's just lumped into those services and billed that way. You also can't bill both for that practitioner CCM time and clinical services using separate codes. Remember, you can include the time for both when you're billing, but you're not going to bill CCM for the practitioner and additionally CCM for the clinical. You're going to look at your time, see which is most advantageous to you, and then bill appropriately. You're also not going to be able to bill for care plan oversight and ESRD assessments. Those are going to generally be part of that CCM. So I know we're running short on time, so I just want to make sure that I show you the resources that we have available. That MLN that I mentioned is out there. I did include that link. I did also include a link to the frequently asked questions that are a little bit scenario based that'll help you. I've also included some links to information about NCCI and MUE edits because that may happen. And then we also have a specialty training page on our website that is kind of a central location for all things chronic care management. It'll link you both to our resources and CMS resources. It does include all of the resources that are here today so that you have those. And looking at the time, I do apologize. I'm not going to be able to get to those pre-submitted questions or the questions in the chat. However, I am going to be creating a follow-up document for all of those, and I will be sending that all to all attendees, so we'll get those questions answered for you. Hopefully some of those pre-submitted questions, those of you that submitted those, we're finding those answers today, but I will be including those in the information that comes out to you all. So to wrap up, I want to be respectful of everybody's time. So in a few minutes, you are going to receive an email that's thanking you for attending. Don't delete that without looking at it. If you attended today for continuing education credits, this is going to serve as your certificate of achievement. That is going to have your completion date and your contact hours. That can be submitted to your accreditation or certification body for access, or excuse me, for credit to get access to those CEUs. If you didn't get it, one of two things happened. Either the automated email, which comes from WebEx Messenger, didn't get through your junk and spam folder, so you may want to consider adding that to your safe sender list, or you attended by phone. In either event, I'm going to ask Ashley to put some information in the chat. That's going to be our email box. You can go ahead and send me an email with the title of today's event in it, which is Study Hall Chronic Care Management. And make sure you give me the phone number you attended from. I'll confirm your attendance and I'll get that certificate out for you. I will continue to take questions. As I mentioned, I apologize. We did run tight on time, so I was not able to get to questions in today's session. However, I do have your questions in the chat and I do have your pre-submitted questions, and I'll make sure those get out to everybody. But I'll also be taking additional questions for the next 7 days at that education mailbox. Just need to include the subject topic for today in the subject line so that gets to Ashley and myself and we can get those questions answered for you. Also, if you have the training materials, if you click on that link in the presentation, that will open up a mailbox that will already have the subject line in there just to make it super easy. If you are calling about a specific claim, maybe you have a claim denial, that does still need to go to customer service because they'll be able to access that claim and advise you more thoroughly. As I mentioned at the beginning, we do like to hear from you. Your feedback does steer everything that we do. As I said, we didn't get to questions today, but we do have our question and answer session tomorrow as well. But we want to hear from you about today's session. What did you like? What could we do better? And also, what feedback do you have for future topics? Your feedback is critical to everything we do, and I appreciate all of you for taking some time to provide us with a little bit of input. Examples of that is that we look at those survey comments and we make those changes. Some of the changes that we've made based on that feedback are adding chapters to our YouTube videos and training indicators to help you better select education. So with that, that does end the presentation for today. We did run a little bit over. Thank you for sticking it out with us for the rest of the presentation. I hope you found today helpful. On behalf of myself and everyone on the WPS Provider Outreach Education team, I'd like to thank you for taking the time to attend today. We know that everybody's super busy and this hour can be tough to carve out. We hope to see you tomorrow in Ashley's interactive question and answer session that's going to also focus on rejections and denials. So if you haven't registered for that, that is still open and it is available on our live events page. With that, this is the end of our session. Again, hope to see you tomorrow. Have a great rest of your day. You may now disconnect.